If I can invite up Dr. Kevin Barnett, and I could again similarly read through a whole history, but what I would say is this: I've now been down here for almost 8 years. I've been blessed to have this role to work with all of you, and I can tell you when I first started, I remember Lindsay and her work around the needs assessment was like, there's one person who you need to talk to, and that was Kevin, and definitely somebody who over the years we've talked with at various times, particularly around when our needs assessment is coming together. But I think there's a great opportunity. We had an interesting dialogue yesterday around equity. So I'm really looking forward to the discussion here today, and I think you're all in for a treat. So Kevin, if I can invite you up, please.
Thank you, Demetrios. Pleasure to be with you. It is still early afternoon, and I know many of you are ready to get on your day, but we are hoping to have a dynamic dialogue with you folks. We're going to move towards a more interactive session, so please do feel free to raise your hand at any point. If you don't, we'll just have a conversation amongst each other. So I really welcome you. Demetrios, Lindsay, the whole team here at HASD&IC, appreciate your leadership, appreciate your thoughtfulness and approach to this, and we're delighted to engage with you folks. I'm going to ask my panel to come up, and I think one of my panelists is going to come on the screen. While the other panelists coming up, I'll introduce my first colleague, and I can say for all three of these folks, I can call them both colleagues and friends. First, on the screen is Roberta Waite. Dr. Roberta Waite is the Dean of the Georgetown School of Nursing, and a colleague of mine on the board of the Trinity Health System. She chairs our Person-Centered Care Committee and brings an immense wealth of experience and expertise in working in inner cities like Philadelphia and bridging that academic, clinical, and community practice and policy arena. So she's going to talk to us a bit about some of the issues in equity in the clinical arena. Then Randy Oostra, who's become a good friend and is an immense leader in the field. Just this week, Randy announced his retirement as CEO of the ProMedica health system in northwestern and southeast Ohio and southeastern Michigan. Randy has done a range of things I couldn't even go into, but first and foremost of them, folks may recognize his name as the founder of the Root Cause Coalition. It's a national group of hospitals across the country that have really embraced this notion of being anchor institutions and thinking and acting deeply on how to build communities and moving beyond simply the provision of clinical care. Last but not least, dear friend and colleague Mark Rukavina. I met Mark, I was doing the calculations about 26 years ago in Boston when he was working for the Cambridge Health Alliance. And this was a part of an AHA initiative called the Community Care Network Demonstration. And Mark was doing landmark work even then in helping to really advance how the Cambridge Health Alliance engaged in inner city communities in the city of Boston. Since that time, he has had an immensely important leadership role with the national group Community Catalyst, which supports advocacy, community organizing groups across the country in engaging and at times challenging hospitals and health systems on a wide range of issues, including medical debt. So he's going to really begin to challenge us to look at how we might engage our communities in a more effective way. Can we bring the slides up and have Roberta on one side and the slides on the other? Terrific. So again, I'm going to be brief, and each of our panelists are going to be brief. We're going to leave plenty of time for discussion. But I want to sort of set the stage here a bit. So before COVID, there were a range of things that were in play that many of us were working on. One of them in particular was this notion of healthcare transformation and how we began to move from our historical focus on fee-for-service medicine to begin to increasingly assume financial risk for keeping people healthy and out of our emergency rooms. Obviously, that journey has been halting, at times accelerating, at times reversing, but nevertheless, it continues to be the direction that we are moving on. And part of that involves our thinking progressively how to move from treating diseases and body parts to treating whole people, to treating people that have common conditions as cohorts, to ultimately beginning to think about treating people in the context of their communities. And that leads us gradually to, from the individual focus to what are some of the social and environmental conditions that are driving poor health. And increasingly, it will become part of our business, part of how we sustain ourselves in the future. Again, in some senses, we're still early on that journey, and COVID sort of threw a wrench in the works in some ways. In other ways, it helped accelerate that work. Part of this is really coming to terms with it. So many things out there that impact people's health that have little to do with the provision of clinical services. And over the years, as I've engaged boards and senior leaders around the country on this, inevitably somebody will raise their hand and say, well, that's not our job, is it? But increasingly, we have to be at the table. We have to be a part of addressing these issues. This isn't something that is on our shoulders alone, but we have to be at the table, and we have to be in a position to strategically address these issues. At the bottom of this chart is one in particular that we don't think so much about. In clinical terms, we call it allostatic load. In lay terms, it's toxic stress. It's not the kind of stress that you and I deal with on a regular basis. It's the kind of stress where you can't pay your monthly rent, your utilities might get turned off, you just got called to your second job and you can't pick up your kids at school. This is the kind of stress that we know has dramatic physiological impacts upon us, and over time, dramatically impacts our health and well-being. So as hospitals, it's not something we automatically think of, but again, as we increasingly assume financial risk, we have to think about that. The other thing we have to think about that has become clear in the context of COVID is our history of racism and ways in which we contributed to the poor health of people in the ways in which we discriminated against people in many of the neighborhoods, particularly in our urban areas. If COVID did nothing else, I think it highlighted for us just how profound the inequities are in our communities and the work that we have before us. Some of the work that we have been doing in this regard involves beginning to think more strategically about where health problems are concentrated. This is looking at a particular section of Los Angeles and using some of the technology. Folks, SpeedTrack is a partner of ours in the work of beginning to apply geographic information systems, looking at utilization patterns, looking how that overlays with a variety of other health metrics, and beginning to think strategically down to the census tract level and below, not only what we do in terms of patient care coordination, not only what we do in terms of connecting people with meeting their social needs, but ways in which we can work with others to begin to impact the social and physical environments in which people live. So those are the kinds of things that we were beginning to really roll our sleeves up and work on, and then of course COVID hit. Now, I won't hit on all of these because you folks have been living it. We've all been living this. And after Carmela's talk this morning, I felt like I needed some trauma-informed care. But I think we all have a real sense of the existential challenge that we face in healthcare. And yet, we have to really roll up our sleeves and continue this work. So, and on top of that, again, the kinds of things that Carmela talked about in the policy arena, with the overlay of the increasing costs that we're all facing in terms of workforce, ways in which private equity is beginning to buy up some of the more profitable aspects of both practices and aspects of our delivery, and the way in which government is acting in a way that contributes to some of the market failures that we have in our communities, despite their best efforts. So, in essence, we have to be thinking about what we're doing in the inpatient care. At Trinity Health, in our system, we're looking at engaging nurses that have retired as virtual nurses and putting together teams and looking at ways in which to maximize care in the hospital. But at the same time, we have to think strategically about what we're doing in our communities. We have the benefit in California that started first with federal funding around ARPA. A lot of money has gone into engaging community health workers. Not a lot of thinking yet about how to sustain the engagement of community health workers. And now the state has kicked another $350 million into training and deploying community health workers. Part of our challenge in that context is not to over-medicalize the role of community health workers, how to make sure that we can take advantage of the immense skills and expertise and sophistication they have in understanding the interplay between place, culture, economics, and health in their communities. And that's part of our work going forward. This is just an example of some of the findings about where the opportunities lie for us in the realm of assuming increasing financial risk. This is a study that was just done by the California Healthcare Foundation, looked at 180 provider groups, over 8.5 million California adults, and looked at variations in primary spend by different providers, and looked at what would be the implications if the bottom three quartiles of primary care spending actually were raised to the spending of the average of the top quartile. And the results they found was the potential for 89,000 fewer ED visits, 25,000 fewer admissions, and over $2.4 billion in savings. Mind you, this is with commercially insured populations. This is not even the Medi-Cal population. So when we look at how much hospitals currently report as community benefit expenditures now in the form of Medicaid shortfalls, it often represents as much as 60 or 70% of what they report. And half or more of that is for treatment of preventable conditions in ED and inpatient settings. So clearly there's more that we can do if we want to be more strategic and more proactive about addressing things. So Carmela mentioned the issue of community benefit and the requirement now to spend 25% of community benefit expenditures on the social determinants. The good news is the state has subsequently noted that they're taking out charity care and public pay shortfalls from that. So as it turns out, for most hospitals, what remains, 25% of what remains, turns out to be not that far from what's already being spent. So it's not even clear that this legislation was thought through enough, even though they're only thinking about what is the amount of expenditures. There's much more thought that could be put on that, and frankly, much more leadership that can be provided on a voluntary basis by the hospitals if we choose to come together. CalAIM has been mentioned. It's often confusing, but it's another $1.5 billion of funding for a variety of supports in lieu of services. CareCourt is another piece of legislation that was passed. It focuses on homelessness. It's only a small proportion, however. There's approximately 161,000 Californians who are unhoused right now. CareCourt will address somewhere between 7 and 12,000 a year. So it's only a small piece, but a welcome addition. So, fundamental questions. As we continue to move towards risk-based payment and begin to come to terms with these profound inequities, real question is what can we do in clinical settings to eliminate the discriminatory practices that still exist and build the workforce of the future? What can we do in partnership with communities to ease the financial burden of healthcare? And as enterprises, how do we really begin to think of ourselves as health improvement systems, not simply acute care providers? To the degree that we stick with the old model, we are at risk of becoming increasingly marginalized in the negotiation for payments with payers, as well as with government agencies. So we need to begin to think about how we diversify ourselves, how do we engage, and how do we become transformed. With that, we can turn off our slides and see Roberta again. And I'll turn it over to you. Roberta, welcome.
Thank you so much. I will share my slides now. Well, thank you for having me. It's great to be here. I look forward to talking to you about how to build equity in clinical and community settings. What I would like to do is really just give an overview about some of the inequities in clinical care and implications for workforce development, look at some things that we haven't known before that we do know now, talk about some obstacles, and then look at some emerging innovations in care. So for me, I wanted to actually, when I thought about this presentation, wanted to start off with this quote, which really spoke to me. Richard Wagamese, one of the leading indigenous writers in North America, states that from the beginning, we are all created equal, and only circumstance and history make us what we appear on the outside. And so much courage, when we think about this, much courage is needed to build equity, which requires going up against a lot of the traditional ways of operating that we do now. But we know we can no longer regard health only as a technical biomedical issue. And I really liked what you just said, Kevin, where you said for hospitals to be health improvement systems. So we really have to think differently. Health requires cross-sectoral action and justice in our efforts to address health inequity. And we know also that the biomedical approach does cure disease, but it alone cannot root out and address health inequity. It must be accompanied by a broader understanding of health depriving forces found in the national and the global political economy, because the origin of health inequity is tied to fairness in the distribution of power and resources rather than a biological variance. So in moving forward, I wanted to start with this disclaimer, particularly since we're talking about health equity. Health equity is not a point of destination, it is a process. And health, we know, is fundamentally political and politicized. And we assume oftentimes that it's not. So in that matter, we know that, it's a scarce resource. Health is a scarce resource, and politics is how we deal with that scarce resource and how we allocate them. Then figuring out how to maneuver these politics to empower people to have sustainable, equitable experiences of long, healthy lives is key to which takes courage and action. And the context of these political policies are deeply based in our beliefs and our narratives that we create, which drive our decisions. And this process is critical because it is not acontextual or ahistorical. So we must recognize that every one of us lives a contested existence, and some of us more than others. So in moving forward and looking at health equity, I want to emphasize that any intentional pursuit to health equity requires courage to ask critical questions of ourselves, our leaders, our institutions. And I would say first, we must ask, do we have the moral and political will to engage in a real process centering health equity? And do we have the will to alleviate health disparities that create to create an equitable society? That's what our goal is. And I use this definition of health equity by Dr. Kamara Jones because it resonates with me, of ensuring the conditions of optimal health, providing resources according to need. So that's not equality, that's equity. Valuing all individual populations equally, and recognizing and rectifying historical injustices, which I think is a linchpin that many get hung up on. So when we think about sort of the baked-in part of inequities, these articles here illustrate how inequities are baked into our US healthcare system. So it's an array of articles that's here. And the way it's baked in, it actually impacts every experience. And in large part, these inequities are due to anti-Blackness. And we didn't get here by accident. It is how we prioritize people, policies, processes, our institutional practices, our cultural representations, and other norms that work in various and reinforcing ways to perpetuate inequity. And these articles provide examples of how racism operates, impacting those who have been racialized and minoritized. And it is essentially imperative that we know that racism, not race, is the vector of disease and health disparities. And we know also that differences in access to well-being creates differences in experiences and outcomes. And this continues to perpetuate systemic inequities. And I would say we have to keep in mind that key to these inequities is power, which is nothing but the ability to achieve purpose, such as bringing about social, political, and economic change. And power is not inherently good or bad. It's the value, depends on its locus, its purpose, and its manifestation. So for example, to change inequities based on being racialized as Black or brown means power sharing and centering people who are most impacted by inequities, because power manifests in how decisions are made, the people and networks involved in these decisions, as well as how problems and solutions are framed and what ideas are even considered in the process. It comes in the form of resources, access to decision-making, alliances and networks, and the dominant stories society chooses to tell about its nation and its people. So these here are some examples. When we think about illustrating how biology has been perceived as a driver of differences in health, linking race to biology, these are some examples here. And this conceptualization that race is rooted in biology really stems from colonization. And historically, scientific racism has emerged from theories of biological inferiority. And we see this from examples such as with Dr. Samuel Morton, who really did a lot of framing this with cranial capacities, looking at white colonizers, Native people, as well as those who were enslaved. And it's important the development of these flawed theories have cemented societal conceptions around race, skin tone, differences, and whiteness as biological concepts. We also see this in the bell curve intelligence theory and the eugenics movement, and more recently with race essentialism, which is key because these things really influence medical guidelines, standards of care. We've seen this more recently with the Black-white differences in estimated GFR rates, and these reinforce erroneous notions that racial and ethnic minorities are inferior. And it's not race, because we know race is not a biological concept. There is no race gene. Race is a socio-historical power construct, and the concept which functions as essential access to social relations and real material life outcomes in the United States. So some of the examples here are, for example, are individuals racialized as Black are seen to have nerve endings that are less sensitive than persons racialized as white. Blood coagulates more quickly. Again, as I mentioned earlier, have smaller brains, thicker skin than persons racialized as white, and have less efficient respiratory systems. So these things are deeply entrenched in the conceptualizations, thought processes, and I would say, I dare say they are still in a lot of the academic books that our medical students, our nursing students, and many of the other health profession students are learning to this day. And for example, with respiratory systems, we know that many of the environmental contaminants and toxins really impact individuals' respiratory systems. So it's not race, it's where we're concentrating people and then what we're exposing them to that has implications for a person's oftentimes respiratory capacity. We also know this from technology and sort of how things are built in behind the scenes and algorithms and how things are tested. But pulse oximetry technology misreads oxygen levels in persons who are darkly melanated. So these are things that we know about that have penetrated our society on a deep level. And we know that there's huge financial implications. The healthcare sector is under immense pressure to reduce healthcare spending while also increasing quality. And we see that inequities here account for $320 billion in annual healthcare spending today, and if unaddressed, is projected to be $1 trillion by 2040. And positive change for this will require action by industry leaders with intentionality in design, rebuilding trust, partnerships, measurement, as well as addressing individual and community level inequities. And when we also think about health equity, we have to also requires an alignment with risk management. And this is linked to quality. And we know there is no equity without quality. And there's no quality without addressing health equity. And so this slide highlights some areas that we really must address regarding health equity, and intentional actions are needed. For example, when we're looking at community, we really need to look at community from the standpoint of what are the assets? Do asset mapping can occur to see where areas require further investment? And then those decisions about what to improve or where to invest and how to improve them is needed. And to do that, we also have to ask some questions about who benefits from them, from the decisions that are made, who gets left out, who is advantaged, because neglecting these areas can preserve and cement inequities that already exist. So we have to design quality initiatives for populations and make sure that we're addressing those who are most adversely affected. Because if we don't, it will lead to less improvement, less sustainability, less trust, and less equity. This slide here really just talks about some of the impediments to equity that we know. The impact I just talked about already of racism and discrimination, our approach that we normally take with our paternalistic approach, we know best, versus engagement with our patients, families, and communities. Limiting our lens to a biomedical lens to health. And so these are examples here, but we have clear strategies for improvement, and that is community engagement, where we truly value the health of all, and increasing opportunities for patients to enhance trust, improving our data measurements and the data that we collect, as well as leadership accountability in developing that culture of belonging and inclusiveness. And I just think this sort of sums it up, because we're not shocked by what we get. Each system is perfectly designed to give us exactly what we're getting today. And I also just wanted to, put this in here. Paul Farmer was just such a phenomenal person. And when he says, when we look at how we treat people, as, his background as a medical anthropologist, physician, and humanitarian, who really co-created and centered a lot of medical outreach, the thoughts that some lives matter less than others, that's really penetrating. And so we have to do better. We have implications also for workforce development. So if we want to build a workforce from that clinical capacity to take action to promote practices that advance health equity, it's going to be essential. And we have to strive to develop world-class education to make sure our workforce reflects society it serves. And, these are some really basic, essential steps that we can take by increasing access, diversifying our workforce. We're looking at admitting people into different institutions and different professions, having holistic admissions and not only going by the highest GREs, looking at funding. We have to do better from a scientific workforce. We must confront structural racism that's embedded in so much of what we're doing, even from a scientific perspective, as well as how we engage and teach the pedagogy, andragogy curriculum that we teach our students, and the experiential learning is key. And then I would just wanted to highlight some obstacles to progress that we have that's here, that's common, because to advance a more equitable process to workforce development, impediments to change have to be tackled on a systematic level. And our individual emotions and behaviors, and I would say our mental framing, provide the launch pad to how we undertake action to advance our work on equity. So issues around fear, our motivation, again, issues power, I have power hoarding here, our willingness not to change, the vulnerability that we have to lean into to something different, and then also the limited imagination that we can have. Some of the emerging innovations in clinical care are listed here. Because of time, I'm not going to go through all of them, but we have a lot in artificial intelligence. Our models of care that we're having, Kevin talked a little bit about, we're starting much more from our virtual models of care. With our nursing shortage, we're having virtual nurses that are supporting newer nurses and mentorship, and also to be able to address patient needs more immediately, so rounding out that team in a different way. Looking at biosensors and trackers that can really be helpful with safety. Health systems supporting upstream interventions, as well as digital tools to improve employee satisfaction. Those are some different ways with some new emerging innovations. And just as we close up, so that the other speakers can talk, and I know we'll open it up, I really think this is so important. As Audre Lorde, an American activist whose writing has challenged racism, prejudice, and bigotry of all kinds, she stated, "We can join together to affect a future the world has yet not conceived, let alone seen." And I think that's our charge of what we're here to do and what we're striving to do, particularly since our focus is on promoting health equity, which will continue to be an enduring process. But I know we're up for the charge, and that's why we have this conference here today. I look forward to engaging everyone in questions, and I'm going to turn it back over.
As usual, your comments are both challenging and inspiring, and I'll ask folks to hold their questions. And I'm going to turn it over to Randy Oostra now to talk a little bit about this from an enterprise point of view.
Yeah, great. And I think we have a slide that's going to pop up here about talking a little bit about our journey with social determinants over the last 13 years. Will these advance? Let me just talk about a couple concerns, and that's not the right slides, but we'll keep going. Anyway, just a couple thoughts here today, and this is a really difficult time to have these discussions. I think when you think about the comments we already had this morning about just financial challenges, and I think what we worry about, and that was the right slide, so thank you for that. And the idea here again is just as you think about strategic planning, it's this idea that we talk a lot about, kind of this microscope, telescope. And that you're focused intensely on the things right in front of you, this microscopic look and the issues we face every day. But the challenge for us is, again, to look up and, from a telescope standpoint, think about the things, that we really want to accomplish, which we already talked about today, and really what it does to the model of healthcare and how we philosophically think about healthcare. And then just the other thing is we think about systems and we think about how we think about these in our own organizations. It's the realization that some people can compartmentalize things and others can't. So If you have financial problems, you have people that you work with every day, including board members, they cannot think about anything else but those problems. And the idea is to be able to compartmentalize those things. And we understand the situation that we're facing, but it's also the work that we're doing. So the idea is to say, yes, we have these issues, we have these things in front of us, we have to focus on those. But oh, by the way, let's think about what we really want to do from a more global position. What do we aspire to do, and how are the things that you know, can we interact on and think about to make an impact. So this is a slide that is 13 years old, and it started 13 years ago with a community needs assessment. I'll be blunt, I've never liked community needs assessment, because 13 years ago, we would put it in our goals, and then at the end of the year when you're trying to, you know, talk about it, you go, what was the goal again? And did somebody have a binder, and you pull a binder off, and you report out a goal, and it really wasn't a big part, although I think a lot of systems, a lot of folks are doing better. And our goal was around obesity. So our board at that point had a foundation, and they gave us $500,000 to create learning maps, tabletop learning maps to take into schools, social clubs. And we did that. Hired trainers, went into schools, went into, you know, Boys and Girls Clubs, the Y. And after about 90 days, the trainers asked for a meeting, so we thought we'd hear great things about the work they were doing. And they didn't look very happy when we sat down, and they said, we have a big problem, these kids are hungry. And it's like, no, we didn't sign up for hunger, we signed up to talk about kids about obesity. And of course, over the last 13 years, we realized that hunger is a major health issue in our country. We just, over the last 20, 30 years of our country, have made it a political issue. And really, again, last night, arriving here, when you listen to the statistics in San Diego, you know, they talked about 28% of people in San Diego being food insecure. When you think about that from a single mom perspective, 30% of single moms in this country are food insecure. For a family of 4, that means they miss 100 meals a month. So if you think about that and that life, 100 meals a month, the challenges you have, and then you think about them walking in our facilities and the challenges they have every day, you know something needs to change. So we started to look at hunger as a health issue. The first meeting we went to was the USDA, and they asked us why we were there. We talked about hunger as a health issue. We started going to all the hunger organizations, the Alliance to End Hunger, Bread for the World, Share Our Strength, Feeding America, Mobile Meals. And they all said the same thing. They never talked to a healthcare organization before. And Reverend David Beckman, who ran Bread for the World, after about 5 minutes said, where the heck have you been? And why haven't we talked about this before? And really what we began is hunger screening 13 years ago. And we did it with a 2-question survey that we all use right now. And over the last 13 years, we've done 5 million hunger screens, and that's expanded to be, you know, the screening for all the social determinants of health. And what it started us to think about is just doing life differently. So we went around with the USDA 13 years ago and did regional conferences with the USDA about hunger. And we actually were going to start those and do those again, the organization that I just left. And one of the meetings, the AARP and CDC came up, and that's how we met Kevin. And they said, we want to work together on this sort of work together. The CDC said, we got this thing called Ebola. It should take us a month or two. We'll get back to you. We never heard from them again. But we stayed with AARP and formed a national organization called the Root Cause Coalition with about 100 national members. And it's a mixture of social-based agencies, hunger agencies, health systems across the country that are really talking about these issues and really trying to share best practices. Excuse me. And so really what it did from that point on, and hunger was a great place to start, we provided short-term food needs. We created an inner-city grocery store in a food desert because no food chain would help us. And today, we consult with people across the country, churches and hospitals, schools, that are forming inner-city grocery stores because no one will come into the inner city and do those things. We've directed our philanthropy toward these initiatives, and a donor who was going to give some money to a project ended up giving us a significant amount of money to build a grocery store, a training center, a financial opportunity center, and really allowed us to hire about 20 people in a neighborhood in Toledo, Ohio that had a lot of issues. and really started to build kind of this whole notion of trying to work better with communities and do what we call today anchor institution work. So we created food pharmacies, we created a farm, we led to the screening of social determinants. And today, not only do we screen patients, of course, with social determinants and do interventions, we screen our employees for social determinants and life purpose. And there's been a lot written about life purpose. And we actually formed a company to do that. And so who we're marketing today are employers. And again, as we think about that work, not only with our patients, it's the same issues for our employees. So again, when you look at a lot of issues that we have, and again, just think about a lot of our lower wage employees and living at the federal poverty line and what they can and can't afford. And really what this slide starts to talk about is progressively moving from hunger to the work with social determinants and then the anchor institution work. So Kevin talked a little bit. We moved 4,000 of our employees into the city, into the inner city, and then began to make a whole variety of investments. Now, that was pre-COVID. Things are a little different today, of course, in workforce. But we started using our balance sheet, if you know anything about the hospital anchor network and the work that anchor institutions do. So we did a lot of things, which we probably wouldn't do today, I have to admit, because of economics. But we bought a hotel out of bankruptcy, and today it's a Marriott Renaissance. We bought a strip club and closed it down. We bought land from the Chinese and converted it into a metro park. We bought retail centers. And the idea that our board had at that time is we're going to use our balance sheet, again, a little tougher today. All we want back is our money. We don't want interest. And to be honest, we got back our money on every single project. A couple that we've left money in. And the idea here, again, is what we've already talked about. Now we can keep moving into talking about more things like we use our philanthropy probably 50% for community-based projects that have nothing to do with the work that we do every day. So we raise money. We just raised money for a Boys and Girls Club, a brand new Boys and Girls Club, a brand new YMCA in the inner city. And YWCA for domestic violence. So actually our philanthropy people actually go do work for other organizations. And the reason we've done that is because they just don't have the resources and have the capabilities to do that. And who better to do this work? And we can get into lots of debates about, who should do this work and who shouldn't. I like to think we're making a lot of progress. I had a chance to talk to a group of CEOs about 2-3 months ago about this work and everything. And the CEO of a very large health system, whose name you would know, nationally, internationally known, couldn't wait for me to finish, raised his hand and said, I completely disagree, didn't say exactly this way, with what you just said. This is not our work. This is not the work we should be doing. We have to keep our head down and focus on clinical work. And I think the point of all this, and now we can add in the whole aspects of COVID and inequities in healthcare, what business are we in? Are we in the clinical business? Inside of our four walls, that's all we care about. Or we actually have a broader definition of really what health is. And that gets to social determinants. I think it gets to life purpose. And it helps also gets to inequities. And I think that's the story for each one of us. It's like, where do we come down on this story of what's health in America? And then the other thing I would ask and leave you with this is what's going to change in the next 5 years? If you look at the American model for healthcare, what's going to change? Will we be sitting here 5 years from now talking about the same issues that Carmela talked about? I was a little deja vu as we saw that slide, because that's the slide we've been using, those slides and those challenges. What is fundamentally going to change in the next 5 years that we have today? Are we going to make social determinants, life purpose, inequities a part of the things that we do each and every day, and comprehensively look at a holistic view to health and well-being? Or are we going to kind of regress, talk about these issues, and continue to be a clinically only focused organization and, as we think about American healthcare? And I think that's a lot of the issue that we'll talk about today.
Thank you, Randy. I'm going to turn it over to Mark Rucavina.
Thanks, Kevin. Is this mic on? Can you hear me? Yes? Great. First of all, I'm Mark Rucavina, he, him, his. If you could pull up the slides. Can I have that clicker?
Oh, yeah.
Yes, I direct the Community Benefit and Economic Stability Project at Community Catalyst. Here's our mission at Community Catalyst. I want to thank HASD&IC for the opportunity to speak with you today and salute all of you for the very difficult work that you do day in, day out. Community Catalyst is really an organization, that we're a national nonprofit, and we're committed to building the infrastructure and power of consumer-based organizations. So some of the policies that Carmela referenced earlier today are probably the result of some of the work of organizations that we work with. You may not be a great fan of all those policies, but we think it's really important that people have a role in the decisions that are being made through policies and programs that affect their lives. I'm going to focus my comments on the community setting and the communities that you serve, kind of the flip side of what Carmela talked about in terms of the challenges you face. Individuals and communities that you work with every day face great challenges as well. While doing this and talking with you, hopefully I'm going to give you some ideas of things that are within your control. Camilla talked about many things, policies that are beyond your control. I'd like to challenge you to think about the policies that are your hospital-based policies or other providers' policies, and to challenge you to think about whether or not those policies help to address or exacerbate inequities that exist. There are opportunities for hospitals. They are very important anchor institutions, as Randy said, and your role can be to address inequities and to also convene other stakeholders in the community, as Root Cause Coalition has done, and many of you no doubt do as well. So just some recent headlines. Anybody see any of these headlines in papers recently? A lot of headlines about hospitals hounding people for pay, people being saddled with medical debt, challenges from attorneys general and others regarding hospital policies. More articles could have been included. I could have included articles from California. Just yesterday, the Lown Institute released a report, Are New York Hospitals Earning Their Tax Breaks? They have a fair share calculation that they use to determine whether or not hospitals are giving back to their communities equivalent to the tax breaks that they receive. So I think these headlines really illustrate that hospital policies, and in particular, financial assistance, billing, and collection policies are a social determinant of health. They really influence people's health in your communities. They can harm, they can hurt, or they can help to mitigate issues that low and moderate income people face in your communities. Most often, these are people who are from historically excluded communities, populations harmed by structural racism, as Roberta spoke to earlier. So these are the numbers, medical debt. It's estimated from the US Census SIP data that there's about $195 billion in medical debt across the country. There's a breakdown by race, ethnicity. You see a pretty significant number of households in the US, somewhere between 15 and 20%, according to SIP data, about 16% of households in the US have medical debt. But when you look at the Black population and Hispanic population, those numbers are much greater. We know that medical debt is concentrated in communities of color. It's a result, again, of structural racism. Black, Hispanic, and certain Asian American and Pacific Islander communities are more likely to be uninsured. So they're more at risk of having medical debt. Many live in states that haven't expanded Medicaid. Fortunately, we're not in one of those states right now. For others, structural racism has limited employment opportunities. So they're in low-wage jobs, jobs that may not provide affordable, comprehensive coverage. So they end up with skimpy coverage with very high out-of-pocket costs. Many low-wage workers have high deductibles, but even modest co-payments can be crushing for people. Simple fact, a lack of health insurance or insurance with high cost sharing pushes people and households further into debt, exacerbating the inequities that already exist. While millions of people across the country have benefited during the public health emergency from the expansion of coverage and protection of people on Medicaid, we're fearful, we're concerned, and I'm sure many of you in the room are as well, that when that public health emergency ends, people are going to lose coverage. And that's something to be concerned about, I think, for all of us. So the questions for the hospitals and the providers in the room are, you know, do your policies help or hurt patients, in particular, low and moderate income patients, when they face costs that are beyond their budgets? You know, there are many reports. There was a report just came out, I saw it in the news today, a report on medical debt from the Alignment Healthcare released a report on medical debt among older adults. Again, significant number of older adults are plagued by this problem. Has anyone seen this report? It just was in JAMA Network a couple of weeks ago, talking about new never events. We know of never events. National Quality Forum a number of years ago talked about medical errors as never events. This was a piece by the former health commissioner of New York City, talking about a different type of medical events, and events that hospitals and other providers should work to avoid. Hospitals should never pursue aggressive debt collection tactics, garnishing wages, putting liens on property, never spend less on community benefits than their tax-exempt status gave them, never flout regulations around transparency, never pay less than living wage, never deliver racially segregated medical care. Okay. We may not agree that these are practical never events, but hopefully we can agree that they're aspirational and events that should be avoided. So yesterday morning was interesting. I opened up my email, and there was an email from Rishi Manchada from Health Begins. Many of you in the room might know Rishi. Many of you might have received the same email message. It was related to a webinar that he had sent out, announcement for a webinar that he had sent out early in the day on Tuesday. The webinar was entitled, First Do No Harm, Healthcare Profiteering, Hospital Never Events and Implications for Racial Equity. And one of the presenters was going to be the author of this study. He went on to issue a clarification about the notification for that webinar. I just want to read what he said. After receiving some feedback about our webinar announcement earlier today, I'd like to offer a revised webinar description below. We work with many underserved, mission-driven, courageous healthcare leaders and providers, each of whom are making great strides towards advancing health equity. We heard from many who are increasingly concerned that predatory financial practices are overshadowing and undermining their good work. Several others actively working to prevent financial harm to patients as part of their health equity efforts. The webinar is intended to inform and further support these leaders and providers. And I want to echo that sentiment as well at Community Catalyst. We feel the same way. We want to collaborate with providers interested in addressing this burdensome problem of medical debt. And I want to offer a few recommendations for how, steps that can be taken and what could be done. So building strong partnerships. I've been writing down pearls of wisdom sprinkled throughout the presentations today. But a major thread, a major theme was collective action, partnering with the community, doing better to educate and work with patients. Building strong partnerships is critical. As in any relationship, building trust is so crucially important. And having trusting relationships with community leaders and community organizations is also important. Audit your relationships with equity in mind. Who helps with community health needs assessments, whether you like them or not? For nonprofit hospitals, you have to do them every 3 years. I know you have a collaborative process down here in the San Diego area. Who engaging those most at risk, clinically and at risk for incurring crushing medical debt is very important in this process. Engaging groups that help people of low and moderate income. And are providing them access to supportive services. So groups like medical legal partnerships, and I believe that many of you have worked with medical legal partnerships in this area, and that's an example, I think, of really good groups to be working with. Groups doing financial strengthening work or work around credit, financial counseling or credit repair work. Again, they know who's most at risk. They know the supportive services out there in the community. Could be a vital resource to you if you're not already working with them. Review your financial assistance and your billing collection policies with your community partners. Get their feedback, get their input, consider that input, and work with them to strengthen those policies so that they better meet the needs of the community that you're working with. And invest your community benefit dollars by funding organizations that are doing work to address equity, doing work that are priorities to the communities, in the communities that you work with. And what's gold for nonprofits is providing unrestricted funding to them to do this work. Focus on your community benefit work to be responsive, as I said, to community needs and priorities. Work with the communities to do this. And we're working on a project right now with the Healthcare Financial Management Association. We're going to be developing some audit practices and best practice guidelines around looking at who gets your financial assistance policies and who's subject to some of the aggressive collection actions to see if they're disproportionately affecting certain populations. So again, look at these issues and also look at who's not completing your applications, because I know many hospitals say that hospitals just are dealing with a lot of people who won't complete the application form. Scrutinize that information. Work with organizations that might be working with people who fit the profile that you're concerned with. And again, look at who's likely to be subjected to aggressive collection actions. Garnishing wages, putting liens on residents and other property, freezing bank accounts, and deferring and denying care are pretty serious steps to take for people who have outstanding bills and are really struggling to pay those bills. So again, figure out ways to work with those populations and organizations serving them. And finally, I just want to say, end collection practices that are harmful, in particular for low and moderate income populations. Be transparent about the legal collection actions that you're going to pursue so that people know what might be coming down the road. And if you take legal actions, you can look at the Healthcare Financial Management Association's best practice guidelines that were issued a couple of years ago. There should be pause points before pursuing legal actions so that you're not going after people who don't have the financial resources to pay those bills. And as I already mentioned, limit some of those aggressive collection actions. And finally, I just want to raise one other issue, which is if you're considering or you already have an arrangement with a lender or a financial service entity that specializes in medical debt, really scrutinize the terms of those deals carefully so that you're not making a problem even worse by extending credit to people that has a high interest rate associated with it. So again, we know at community catalysts, hospitals are vital institutions in their communities. You've been stretched during the pandemic. We heard about that throughout presentations earlier today. So have many of your patients been stretched during the pandemic. So I encourage you to look at your policies, take steps to avoid jeopardizing goodwill, and frankly, then having to distract you from the work that's central, which is providing important care and services in your community. So thank you for the opportunity to speak today. Turn it back to you, Kevin.
Thank you, Mark. Can I ask the folks to bring Roberta back to us? There she is. So obviously, core theme here is equity. We're talking about our hospitals, of course. We all have a deep wellspring of goodwill towards hospitals. Nobody wants to lose the hospital in their communities. And yet, despite the ways in which folks rolled their sleeves up during the pandemic, we have challenges on many fronts. And some of those challenges, many of those challenges, in fact, as it relates to thinking in terms of how do we build equity in a profound inequitable society? What are ways in which we can act? What are ways in which we can build working relationships with our communities, with local policymakers, with others, to begin to address these issues in a more effective way? The good news, what I hear from so many leaders like Randy around the country in the last 6 months, is a deep commitment to say we've got to do something on the ground in our communities, far more than we have before. So there's real interest and commitment to do that, but we need to figure out And there are different steps that have to be taken in each communities. But that ethic of shared ownership, of how we are at the table with other sectors, with other large employers, how we work with local policymakers, and most importantly, how we work directly with our communities is a critical part of that process. As I thought might be the case, given the breadth and depth of the wisdom and experience of the panel, we had a few more words to say than we had planned on, but we still have time for a few questions. Would anyone like to offer a question or an observation?
Is there a common set or a common understanding of the metrics that would best characterize a community that has, where a community is on the spectrum between total inequity and awesome equity? How would you measure equity in a way that would facilitate comparisons with other communities so folks knew where they were?
Panelists?
Yeah, I can just give you some examples. So when the first stories came out about inequities, our board members were like, they didn't believe it, you know, and they were like, I can't believe this isn't true of our doctors. And at the next board meeting, a couple of our doctors shared examples. One was an OB-GYN who caught himself. He said, you know, I had seen some patients and I realized I was treating black women different than white women. And he got very emotional about it. And so, you know, I think when you begin to look at statistics, whether it's cardiology, whether it's OB, other areas, you can begin to benchmark and begin to study your own, kind of your own profile for your own system. So I think it starts there. I think there's data out there, and I think it's just comparison again. Are there differences? You look at cardiology and the testing differences if you're black versus white. I mean, they're pretty dramatic when you look at studies. Is that something that's going on in your system? So there are studies out there. What we challenged our folks to do is to highlight or to target a few specific areas that we began to start working on to say, okay, let's start looking at our data. Let's start understanding how we are treating different races differently, and then let's kind of compare it to see what we can find nationally. So it does, you know, I don't know kind of a national scorecard or anything today, but at least that was our approach that we took initially to start looking at data and compare ourselves against others.
Just to make sure I understand your question, you're asking in part, give me an example of a community where we're doing a really good job of building equity.
What are the markers to tell you this is a community that has made a lot of progress in equity?
I'm going to restrain myself for a moment and give Roberta a chance to respond.
Well, I think you have to look at some comparisons overall and have some sort of baseline data. You know, one of the things that I was going, I don't know if this relates to your question or not, but look at some of the benchmarks related to women's health and morbidity and mortality, right, and outcomes in that area. We know that from an equity standpoint, that we still have worse outcomes where it's not just from a financial standpoint for women, but it really does center a lot on multiple factors that revolve around race and racism. We have poor outcomes for individuals who have higher levels of education, who are racialized as Black and brown, than individuals who are white that have high school education, right? So when you're looking at resources, it's not because of insurance. It's not because of other sort of resources that we commonly think of and access to healthcare providers. So we have to look at what are those very specific areas that really are consistent that produce inequities. And I say that racism is one key piece of how individuals are treated when they are, in general, in accessing care, but also in many realms of life experience, because our outcomes regarding equity are not just from a medical lens, but it's also from our lived experience and that social lens as well. So metrics have to go across, not just from a biomedical lens.
I'll give another example where the statistics are particularly striking. A bit up the road in Fresno, Southwest Fresno, the average life expectancy is 59.8. And the zip code immediately to the east, it's 80.2. And in that zip code in Southwest Fresno, the it has also one of the highest rates of food insecurity in the country. And those neighborhoods are the neighborhoods of all the people that pick the fruits and vegetables that have created the Central Valley as the breadbasket of the nation. And so they live in houses and in complexes with 30-year-old carpets and cockroaches and dust mites, and their children have high rates and high acuity of asthma. There are a range of factors you can measure of both the incidence and acuity of a variety of chronic diseases that exist. So there's a number of metrics that we can use. And the metrics that we use in the analyses we've been doing with SpeedTrack really get to preventable ED and inpatient utilization, looking at a variety of chronic diseases. And clearly, when we look, particularly when we drill down to the census tract level, we find rates that are as much as 5, in some cases even 10 times higher than that for the county average. So that's a good starting point, particularly to the degree that we are operating with contracts that are risk-based in their payment. So that's a way to begin to line our business strategies with our efforts to build equity in our communities.
So we have time
Kevin,
for...
I just wanted to give one other example here as well. When you were just talking, it rang true. I just recently moved to the Washington, D.C. area, and we're looking at different wards. So Ward 7 and 8, which has probably triple the population as the other wards, they have only 3 grocery stores. And then when you go to the ward that has probably a quarter of the population, they have 12 grocery stores. So even from that dynamic of what's available and accessible from a food nutrition standpoint, from equity and how that impacts health and the food and the type of food that's available, I think that's important as well. So there's so many different, I would probably say, metrics that you could pull depending upon how you want to focus.
Just going back to the examples that Randy shared, that ProMedica and its investment in the inner city in Toledo, they went mostly towards outputs initially. It went into these communities, could see that there was no green space, there was property that was not being used. There's all kinds of potential, and they said, let's drop our bucket and make some investments. There's no grocery store here. We need a grocery store. Now, it's prudent to be thoughtful about how one does that investment to ensure its success. But in many cases, those kinds of investment opportunities are right in front of us. If we have the courage to step up and to begin to demand that others step up. This is, I think, one of the most underutilized powers of the healthcare sector in this country is beginning to link arms with their otherwise competitors and beginning to put pressure at the local policy level for making sure that people have access to affordable child care, for addressing some of the drivers that are bringing people in their emergency rooms. We need to have we need to start having those conversations and not say that's somebody else's job.
So I know we're at time. We're actually over for this panel, but what is evident is there's a lot of passion around this topic and a lot of interest. And Kevin and group, Roberta, thank you for joining us all the way from the other side of the country. Round of applause, please.